So dear students, today's lecture is dedicated for asthma in children, management and prevention. So what's asthma? Let's give us a simple definition. Disease is chronic inflammatory disorder of airways, which is characterized by airway inflammation, airflow obstruction, and airway hyperresponsiveness. If we'll give for asthma more scientific definition, or in that case, asthma, it is a chronic inflammatory disorder of airways. The chronic inflammation is associated with airway hyperresponsiveness. Airway become obstructed and airflow is limited when they are exposed to various risk factors. Let's see asthma causes. It is recurring episodes of wheezing, breathlessness, chest tightness, coughing, particularly at night or early morning. Asthma is a disorder defined by its clinical, physiological, and pathological characteristics. So, clinical feature of predominant clinical feature, it is a history of episodic shortness of breath, particularly at night. The main physiological feature of asthma is episodic airway obstruction, which is characterized by airflow limitation. The dominant physiological feature is the airway inflammation, sometimes associated with the airway structural change. There is normal and inflamed bronchial tube, and asthmatic and normal bronchi. Pathophysiology, early acute. These changes cause bronchial hyperresponsiveness and obstruction. Airway obstruction increases resistance of airflow and decreases expiratory flow. Late asthma response occurs in cases of a significant allergen exposure. Recurrence of symptoms appears in 4 to 20 hours after initial attack due to persistent cellular activation. It can be more severe than initial attack. So, untreated inflammation can cause long-term airway damage that's irreversible. What's triggering factors? During asthma pathophysiology, we have triggering factors. It is domestic dust mites, animal fur, for example, cat's fur, air pollution, cockroaches, pollen, tobacco smoking, and occupational some irritants. Triggering factors, it is respiratory, maybe viral, chemical, maybe, strong emotional expressions, drugs like aspirin or B blockers can cause also asthma attack. Potential risk factors, we will divide into host, environmental, and host factors, genetic predisposition, some familial, familial have genetic predisposition for being asthma, airway or bronchi is more allergic than other family. Yes, atopy. It's onset of allergic reactions. Atopy or predisposing for allergic reactions. Airway hyperresponsiveness. Some people have hyper-responsiveness than others. It is strict individual, gender, male, female. Males have more chances to get asthma, taken asthma as a chronic disease than females. Race or ethnicity also have an important role during defining host factors. Next, environmental factors. Indoor allergens, outdoor allergens, occupational sensitizers, tobacco smoking, air pollution, respiratory infections, socioeconomic status, family size, diet and drugs, obesity. These all factors can cause, if factor will plus with cause, then we may get asthma. Diagnostic asthma. In order to diagnose, clinical diagnosis supported by certain historic, physical, and lab changes. History of episodic symptoms of airflow obstruction, breathlessness, wheezing, chest tightness must be. Cough. Response to therapy. Cough, which is response to therapy, it is response to therapy, it's we may think about asthma. Episodic symptoms after an incidental allergen exposure, seasonal variability of symptoms, positive family history of asthma and atopic disease. Consider asthma if any of the following signs or symptoms are present. Frequent episodes of wheezing more than once a month, activity-induced cough wheeze, cough particularly at night during periods without viral infection, absence of seasonal variation in the wheeze, symptoms that persist after age 3, the child's colds repeatedly go to the chest or take more than 10 days to clear up. Symptoms improve when asthma medication is given. We may think about asthma in that cases. Symptoms occur or worsen in the presence of. These symptoms will be worsened or will be occur when animals with fur, aerosol chemicals, changes in temperature, domestic dust, drugs, accessories, pollen, respiratory infections, smoke, strong emotional expression. Its next step to diagnose asthma by clinical signs. We have diagnostic asthma with following symptoms. If these symptoms will occur or worsen with these symptoms, next symptoms, we will think about asthma. So dyspnea, airflow limitation, hyperinflammation are more likely to be present if patients are examined during symptomatic periods. Physical signs reflecting severity, cyanosis, drowsiness, difficulty speaking, tachycardia, hyperinflated chest, use of accessory muscles, and intercostal resection during breathing. Yes? Physical examination, respiratory rate, work of breathing, aeration, degree of wheezing, supportive data, pulse oximetry, peak expiratory flow rate, peak flow, yes, chest radiograph, lung function. In order to diagnose asthma, we have to measure lung function with spirometric method, forced expiratory volume, and peak flow meter. Spirometry, it is a preferred method of measuring airflow limitation and its reversibility to establish a diagnosis of asthma. Forced expiratory volume in 1 second, EV1, an increase in 20% or 200 milliliter after administration of a bronchodilator indicates reversible airflow limitation consistent with asthma. Peak flow meter, it is shown electronic and electronic table and that mechanic peak flow meter. Patients with asthma have daily cards to record symptoms and peak flow changes. older than 5 years who can write, yes. They will keep a peak flow diary. They will watch their condition, and they will predict asthma attacks, prevent by themselves. That's why they records. It is so convenient for patients. Classification: mild, intermittent, mild, persistent asthma. Mild, in case of mild intermittent asthma, symptoms less than once a week, brief exacerbations, nocturnal symptoms not more than twice a month, peak flow meter or 18% predicted, or during 1 second we will measure what peak volume of air. Its variability will be more than 20%. Mild persistent asthma, symptoms more than once a week but less than once a day. Exacerbations maybe affect activity and sleep. Nocturnal symptoms more than twice a month. Peak flow meter change less than 18%. And during 1 second, variability 20 or 13%. Moderate asthma, symptoms vary. Exacerbations maybe affect activity and sleep. Nocturnal symptoms more than once a week. Daily use of inhaled SABA, short-acting beta-2 agonists. Short-acting agonists. Peak flow meter 18%. Severe persistent asthma, symptoms will be daily, frequent exacerbations, frequent nocturnal asthma symptoms, limitation of physical activities, percent will be peak flow meter percent will be more than 60%. So classification, yeah. We have severity of asthma, exacerbations, mild, moderate, severe. It's according to talks, breathlessness, normal mental status, mild tachypnea and expiratory wheeze, good aeration, oxygen saturation, and peak flow meter change. Due to these all parameters, we will have moderate and mild severe course of asthma. Treatment, medications, bronchodilators, sympathomimetics, bronchodilators, the anticholinergics, inhaled corticosteroids, biologic response modifiers, leukotriene receptor antagonists, mast cell stabilizers, and methylxanthine derivatives. Treatment of mild asthma. Frequent SABA are the standard of care. Use of NIUB or MDES are each responsible. Most will require just 1-2 treatment. Those who are SABA unresponsive may benefit from systemic corticosteroids. Most will be discharged home. Management moderate asthma. Albuterol, NIUB or MDIS, prednisone, 2 mg/kg daily intramuscle or with nebulizer therapy. If it's and Atrovent next. If there is no improvement, you have to hospitalize. Or there is slight improvement, continue albuterol every 45 minutes. Or we have marked improvement. Discharge, you may discharge home patient. Management, severe asthma, you have to monitor pulse, respiratory rate, oxygen saturation. Supplemental oxygen, 0.15 mg/kg albuterol by nebulization. Atrovent, good response, poor response. In case of good response, continue with an approach to moderate asthma. In case of poor response, terbutaline or epinephrine intramuscle, methylprednisolone 1-2 mg/kg intravenous, albuterol by nebulizer therapy, 25 mg/kg intravenous magnesium sulfate. Treatment goals are following. In case of acute severe asthma episode, correction of significant hypoxemia with supplemental oxygen, rapid reversal of airflow obstruction by using repeated or continuous administration of an inhaled beta-2 agonist, early administration of systemic corticosteroids, for example, oral prednisolone or intravenous methylprednisolone, reduction in the likelihood of recurrence of severe airflow obstruction by intensifying therapy. Asthma attacks require a prompt treatment. Oxygen is given at health centers or hospitals if the patient is hypoxemic. Inhaled rapid-acting B2 agonists in adequate doses are essential. Oral glucocorticosteroids, 1 mg of prednisone kg or equivalent during 24-hour period, introduced early in the course of the moderate or severe attack, help to reverse the inflammation and speed recovery. Methylxanthines are not recommended. We will not recommend if used in addition to higher doses of inhaled 2 agonists. Theophylline can be used, however, if inhaled 2 agonists are not available. Controlling medications, inhaled corticosteroids, systemic corticosteroids, leukotriene modifiers, sodium chromoglukide, chromalin sodium, niodochromial sodium, methylxanthines, long-acting B inhaled agonists, long-acting oral B2 agonists. Classification of asthma by level control is more relevant and useful. Level of asthma control. If we are prescribing some drugs and we have to control level of asthma, yes, characteristic, exacerbations, daytime symptoms, limitations of activity, according to nocturnal symptoms, need for relief or rescue treatment, lung function. According to these all properties, we will control level of asthma. Mild persistent asthma, long-term control, anti-inflammatory treatment in the form of low-dose inhaled corticosteroids or non-steroidal agents. Some evidence suggests that leukotriene antagonists may be useful as a first-line therapy in children. Quick relief, short-acting bronchodilators in the form of inhaled beta-2 agonists, short-acting beta-2 agonists, it is SABA, should be used as a need for symptoms control. Use of short-acting inhaled beta-2 agonists on daily basis or increasing use indicates the need for additional long-term therapy. Moderate persistent asthma, long-term control, and we have quick relief. In case of long-term control, daily anti-inflammatory treatment in the form of inhaled corticosteroids is preferred. Otherwise, low or medium dose inhaled corticosteroids combined with a long-acting bronchodilator or leukotriene antagonist can be used, especially for control or nocturnal or exercise-induced asthmatic symptoms. Quick relief must be short-acting bronchodilators in the form of inhaled beta-2 agonists should be used as a need for symptom control. The use of short-acting inhaled beta agonists on a daily basis or increasing use indicates the need for additional long-term therapy. So it was a quick relief of asthma, and treatment of asthma is over. So today's lecture is, I will finish this lecture. If some questions will be, you may write to my address or